Thank you very much, Mr. Chairperson. I'm very pleased to have an opportunity to participate in this session. My disclosure information. Why are LB summit BT or intramural BT ablations so challenging? Let me share the gross histology of two explanted hearts during heart transplantation. This is 57 years old man with dilated cardiomyopathy who underwent 2 times of BT ablations. This is a picture of explanted heart taken in the operating room for transplantation. The endocardium was almost completely burnt white due to previous ablations. However, unfortunately, there was almost no transmurality except for the place of a steep ball. So I was impressed, considering that I had used a contact force catheter for this patient before. This is another case of explanted heart from 64 years old male patient with lamin cardiomyopathy. Compared to the previous patients, transmural lesion were quite visible. I have learned something after this dissecting these two explanted hearts. First, we must consider tissue character during VT ablation, not only the physical parameters such as contact force, impedance drop, or EGM changes. Second, endocardial mapping and ablation are uncertain because we could miss the epicardial focus. Therefore, the epicardial map may provide additional information regarding subepi or intramural pathology, BT mechanism, or lesion formation. However, epicardial puncture still carries a complication risk of 8 to 10%. Therefore, a practical method that can replace routine epicardial puncture might be coronary venous map. Dr. Fermin Garcia proposed this decision tree, and you can try endocardial ablation for intramural or endocardial foci. For the subapical focus, if the ventricular wall thickness is less than 14 millimeter and the endocardial activation is slower than epicardium by less than 7 milliseconds, endocardial ablation is possible. In this systematic decision-making process, the coronary venous catheter is very useful to identify the subepicardial or intramural foci that can be treated by endocardial ablation. As seen in the cadaver specimen, the thickness of AIV enter into vertical vein and the corresponding endocardial side is very, very thick. So you can estimate the thickness and activation using the AI venous mapping assisted by 3D map or fluoroscopy. Please remember that you can try endocardial ablation when the wall thickness is less than 14 millimeter and the endocardial delay is less than 7 milliseconds. You can conduct sub-selective coronary venous mapping other than AIB. This is coronary vein anatomy published by Baldarabano. In fact, aerial view is better to distinguish the small branches of outflow tract without overlapping. This is very steep LAO view, and the vein passing between two outflow tracts is the communicating vein, and the vein that directs downward from the AIB is septal branch. In this figure, the vein that is bent at the right angle from the AIB and passes in front of aorta is communicating vein. Even in case of a summit VT, where endocardial ablation is possible, a more powerful ablation tool is required to create a transmurality. I always use half-normal saline irrigation for LVVT ablation. Half-normal saline reduces the electrical charge density, which increase the impedance around the ablation catheter and increase the lesion size. Simultaneous unipolar RF ablation is also a very effective method if two RF generators are available. And placing the two catheters in the perpendicular orientation is more effective for large lesion formation and allows for up to 40 watt, 3-minute ablation. Bipolar RF ablation has traditionally been used, but it is difficult to assess the lesion direction with risk of vascular complication. So to increase the lesion size, an irrigated tip catheter is recommended for the active catheter and endocardial surface An 8 millimeter tip catheter is recommended for the intracoronary vein return catheter. Needle ablation catheter has also been developed, but it is not popular due to the risk of a heart block or tamponade. Transcoronary venous ethanol injection is also an effective method, but it creates a fairly large lesion formation and carries a risk of creating new scar lesions. Next, I will briefly introduce 3 cases of intramural VT ablations that were recently performed. This ECG is from 39 years old male patient with non-sustained VT. You observe a precordial positive concordance without precordial transition and lead 1 negative QS wave. This is typical left coronary concept or LV summit PVC appearance. This patient underwent endocardial NAVIX LAT map first while performing AIB mapping with microcatheter. This is a microcatheter and locates quite far from his bundle area. This red sphere is his bundle area. And the epi-endo relationship with epicardial AIV catheter could be seen. And the endo-epi thickness appears quite thick when viewed on the fluoroscopy imaging. The patient's PVC shows a near-field earliest activation and palatal reversal between AIB mapping catheter, and the low amplitude far-field potential was observed at the endocardial side ablation catheter tip, suggesting subepicardial focus. And the PVC was suppressed within a second during 50-watt RF ablation, PVC, and disappeared. 50-watt RF delivery at this location and was successfully treated with hypo long duration ablation for 2 minutes. The second case is 18 years old male patient referred from non-sustained VT associated with dilated cardiomyopathy, ejection fraction 40%. He weighed 119 kilograms, had KCN A5 and SDH8 mutations. ECG shows PVC of LV basal origin and deep S waving lead 1, long intrinsic deflection time. It suggests highly possible LV basal anterolateral epicardial origin PVC. Although he was 18 years old, his large coronary vein allows the catheter venous mapping using deflectable shears, and the earliest activation site map was obtained from anterolateral branch of a great cardiac vein, and QRS morphology matches 96% with a perfect entrainment pacing outcome. In the 3D coronary venous map, epicardial unipolar map also shows QS map pattern, and the VT disappears with an intravenous single ablation, PVVT, and eventually terminated. Yes, narrow QS. At 3 months post-operatively, both ejection fraction and cardiomegaly normalized in this patient. The third case is a patient with hypertrophic cardiomyopathy VT with transmural reentry. This is 35 years old male patient with mid-ventricular type HCM with titin and MIPM mutations, and he had previously undergone 2 VT ablations procedure due to ICD storm. He had a severe apical aneurysm. This is apical aneurysm. Okay. MRI shows that the aneurysm scar was connected to very thick papillary muscle. This is make the creation of an intratransmural lesion very, very difficult. Because we had previously attempted endocardial ablation, we began this time with apical VT mapping first, and sustained VT morphology was apical posterolateral origin consistent with apical aneurysmal scarring. This is mapping catheter and the aneurysm. Because the VT was hemodynamically stable, the apical VT map was first obtained. Beautiful reentrant activation is observed at aneurysmal scar border zone. This is border zone. And ice crowding and line of block were visible here. And this creates a reentry circuit involved a part of endocardium through transmural activation. This is epicardial map. So line of block suggests this BT coming through the endocardium and come back to an epicardium, transmural activation. So when looking at the epicardial propagation map, you should imagine the activation of line of block area passes around the endocardial papillary muscle. And this is a 3D hyperboloid model. Okay, EGM interpretation allows us to identify entrance, isthmus, and exit site based on QRS complex in this HD map. Overdrive piecing performed at this isthmus location resulted in perfect concealed entrainment with 94% match of QRS morphology. So epicardial ablation easily terminates the VT, but as expected, 5 different VTs with similar QRS morphologies were induced. After adding LV endoablation and finally performed the RB map, this is RB epicardial ablation, and then we conducted RB map. This is RB apex. LV aneurysm compresses RB apical aneurysm fold were observed. Therefore, RF ablation was also added in this fold in RB. So we compare the sinus map acquired from epi and LV endo and RV endo, and ILM and isochron crowding were observed along the skull border zone. Here, okay. This is skull border zone. And all these areas were additionally ablated before completing the procedure in this patient. So patient is so far no recurrence of EP. As we saw in the last case, an accessible spot may exist in intramural VT or semi-VT. What should we do in these cases? This is vintage technique, a preclinical study of which was recently reported. This is a specialized method for septal VT or papillary VT using very stiff guide wire used for the peripheral intervention to penetrate the septum and target it with hyperablation. Many people, including myself, are eagerly awaiting for pulse-field VT ablation technology. Recently, the result of European VT ablation registry utilizing Sphere 9 was reported. This is so-called ALVA trial. While the included patient population was diverse, the deaths and transplantation rate in 5%, and stroke in 1.6%, and redoablation in 32%. Key point to note is that PFA could overkill tissue, may overkill patient with heart failure. Ultra low temperature cryoablation can be considered as another prosperity energy source. This is cryo-QVT trial conducted with adagio system demonstrated relatively reasonable outcome. And although the stiff catheter profile still has limitation, it is expected to be a good indication for LV semi-VT. So this is my take-home message. Coronary vein mapping provides an excellent landmark for successful LV summit or intramural VT ablation. Remember, 14 millimeter thickness and 7 millisecond epi-endo time difference to define the intramural VT accessible by endocardial ablation. Careful watching for the far field of signal is key to targeting intramural VT endocardially. Coronary vein or epicardial HD map may visualize intramural VT target or circuit. Half normal saline, hyper long duration RF, simultaneous unipolar or bipolar ablations could be effective for deep intramural foci. New technologies such as vintage PFA or ultra low temperature cryo will increase the success rate. Thank you very much for your attention.